My name's David Hodgins. I'm the principal investigator of the Prairie node of CRISM, and I'll tell you a little bit about CRISM for those who don't know about it in a few minutes. I also had the privilege of working on this project since its inception. So we're going to today tell you the results of the TOP project, which is treatment of opioids in psychosocial and recovery-based programs. I'm going to be joined by Amber Haid, who is the project coordinator at the University of Calgary, and Capri Rasmussen, who is the clinical administration manager for the Adventa Center of Excellence for Women with Addictions here in Calgary. And it's the premier women's treatment program in Alberta, for sure. Lurking in the background are Barb Fornsler from the University of Saskatchewan, who works with CRISM, and also Denise Adams, who is the Prairie node manager. I wanted to pay tribute to the lands. I have the privilege of living and working on Treaty 7, which includes the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, which includes the Chiniki, Bearspaw, and Goodstoney First Nations. And the city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. And we also acknowledge the disproportionate impact that the drug poisoning crisis has had on Indigenous peoples in Canada, resulting from the intersection of social determinants of health and the enduring effects of colonialization. My slides are not moving ahead here. Let's see what I can do here. Oh, slide 4. Okay, so in terms of an outline, I mentioned I'll tell you a little bit about CRISM. I'll tell you about the background of the TOP project, which has a few different parts to it, a few different phases. And I'm going to talk about the first 2 phases. The first one is a scoping review that we completed. The second was a national survey of addictions, psychosocial addictions treatment programs. I'll present the results. And then I'm going to hand it to Amber, who will talk about some of the qualitative work we did with specific programs, and she'll introduce the practice support document that we produced. And then we'll pass it to Capri, who's going to talk about the experience at Adventa of some of the challenges and successes at helping people with opioid use disorder issues. Sorry, my slide advancing is paused here. So CRISM, many of you will be familiar with CRISM, but if you aren't, I encourage you to spend some time investigating it locally. So there are 5 geographic nodes for CRISM, 1 in BC, the Prairie node, 1 in Ontario, 1 in Quebec, and 1 in the Atlantic provinces. And so each of us has our own website, but there's also a national website. And the purpose of CRISM is to basically translate research into practice and policy. And membership is it's not just a bunch of researchers. It's sort of a group of a wide-ranging group of people with lived experience, policymakers, service providers, and researchers and students. So I encourage you to check out your local node and consider affiliating. But there's also lots of different resources available on the website, including lots of information about this project, for example. So let me tell you about this project. So the TOP project was funded through the CRISM Emerging Health Threat implementation science program. And this was a group of actually 12 different projects. So this is one of 12 projects. And you can see on the website some of the other projects, and I'll refer to them. And so CRISM, as well as having local activities, has national level type projects. And these 12 projects are an example of that. So although the Alberta group, or not the Alberta group, the Prairie group led the project, we had a leadership group that was comprised from people across the country. And you can see the membership here. And there were some other people who were members earlier as well. It was funded through CIHR and Health Canada. So the notion of this particular project was to try to understand kind of where things are at in terms of how people with opioid use disorder, what kind of treatment they receive when they attend psychosocial programs. And, traditionally, there are kind of two worlds for people who, initially it was people who were using heroin. They might go to a methadone program, or they might go to back in the old days, a 28-day residential program. And these were two very different worlds, and philosophically quite different type of worlds. Now, over time, of course, psychosocial treatment programs have become more varied. There's certainly lots of residential bed-based programs, but there are many day programs and outpatient programs. And there's more kind of medical involvement, I guess, in many addictions programs. So what did that mean? What does that mean in terms of how people with opioid use disorder receive treatment? There are some, very good practice guidelines available for how to provide the pharmacotherapy, so the OAT, or the opioid agonist treatment. So CRISM has a set of guidelines that are very, very practical and very specific. They're available on the website, and I encourage you to look at them. They are currently being updated, so they may change sort of in the next couple of years. But essentially, the first line of treatment, it's no longer methadone, it's Suboxone, which is buprenorphine, naloxone kind of combo, which has a better safety profile and is also more flexible in how it's dosed. So that tends to be the first line of treatment, or the recommended first line of treatment. And then methadone is the second line of treatment. And we're not going to talk about that much today. That's very well established. Those guidelines recommend that psychosocial support be provided alongside pharmacotherapy. And I'll make some more comments about that sort of in a few minutes. So then the question is, well, what about people who, for whatever reason, take the pathway towards psychosocial treatment and have opioid use disorder? What's happening these days? And that was sort of part of the rationale for this particular project. So, the three kind of components of the project: the scoping review, treatment survey, and case studies. The scoping review, sorry, there's still a big pause with this. Often in research projects these days, you start with some sort of systematic literature review. And we decided that really what was called for in this circumstance was a scoping review. And a scoping review looks at very broadly kind of what's been published about a topic, as opposed to specifically looking for randomized clinical trials or, a certain subtype of study. So we really wanted to see sort of overall what has been, what do we know about psychosocial approaches to treating opioid use disorder with or without pharmacotherapy. That was our overall question. And what we found was a large number of studies. And in fact, 48 years of research, there were 305 studies that we included in the scoping review. And some of them are randomized trials. We also looked at qualitative data, qualitative studies. We looked at cohort studies that follow groups of people over time. And all of this is available in a web, in a database with a dashboard. So if you're looking for literature in this area, this is pretty up to date. I think there were 305 studies initially when we published this paper. We've updated it more recently, and so there's a whole bunch more studies there. So if you go to the Prairie CRISM website and follow the links, you can find this dashboard if you're interested in a particular pieces of information. But here are some observations from this big scoping review. First of all, there was very little Canadian research. I think it is about 2% of the studies were from Canada. The majority, about 2/3 of them, were from the US, and then Europe and Asia and Australia were the other sources of information. About 80% of the studies focused on the impact of adding a psychosocial treatment to pharmacotherapy. So they were really about, can we improve OAT, the pharmacotherapy? And most of the studies, from when they were done, it was methadone. The results generally are mixed, but there's general support for it, for adding some sort of psychosocial treatment, in particular for individuals with comorbid mental health problems. So essentially people with more complicated situations, there's an added benefit. So intuitively, it feels like there should be, and there's some support, but it really kind of mixed findings there. And the types of psychosocial treatment, vary a lot. There's a lot of studies on contingency management. So basically providing incentives for individuals to stay engaged in treatment and participate in different aspects of treatment, or in particular to have drug-free urines while they're taking OAT. But there are also studies on CBT and generic addictions counseling and group therapy and so forth. Now, at the same time, there was a more nuanced review conducted and published by some of our colleagues in Ottawa, you can see here, that specifically looked at the different types of psychosocial treatment. And the conclusion of this review is that contingency management is the add-on that has most support, and the effect is really in terms of improving engagement in OAT. So engagement is pretty important. It's pretty central. And so, this review, of course, concludes that more rigorous research is needed, but really would direct OAT programs to include contingency management as part of their offering to improve outcomes. But in terms of our kind of question about standalone psychosocial treatments, relatively very little research, and most of it is kind of older research. And currently, basically, there's not enough evidence to conclude that psychosocial treatments alone are adequate to treat people with opioid use disorders. So it's kind of, we're in the situation of a lot of people are going to psychosocial treatment. That alone, may not be sufficient, or maybe that's not the case in our current treatment services. So that then brought us to the treatment survey, part of the project. And this is an article that's published of the results. This is actually, you can download this article. That first article from the scoping review unfortunately is behind a paywall, so we'd be happy to send you a copy if you're interested in it. And as I mentioned, that whole database is available on the web. This paper, though, can be downloaded if you're interested, but I'm going to tell you what the results are. So basically, we put together a list of all of the psychosocial programs we could identify across the country. And we found 676 programs. We excluded programs that were actually opioid dependency clinics, so OAT clinics. And we excluded detox facilities, facilities that primarily provided detox and not treatment. And we also excluded indigenous programs. And the reason for those exclusions was that some of the other of the 12 projects focus on those, and there are separate reports on those types of facilities. So at the end, we had 214 sort of completed surveys that we were able to analyze. So you can see here that there were slightly more outpatient programs than day programs or residential programs, but we had a nice distribution of all three. One of the challenges we discovered earlier, it seemed very easy to send a survey to a program and get a description, but we had to figure out, well, what is the definition of a program? And of course, some programs have beds and they have day program, or they might have a day program and an outpatient program, or it sort of very quickly became complicated in terms of you didn't want these poor service people to have to fill out multiple surveys for different aspects of their program. So we kind of developed some rules of how to do that. But overall, among these programs, we asked about the treatment goals for clients, and you can see that about a third were abstinence-focused programs, and then another 10% it was abstinence, at least for the problem substance. And then the remainder programs worked with clients to determine the best goal, whether that be abstinent or some sort of moderation goal. So that was actually interesting to kind of see the current situation across psychosocial programs. We asked programs to either using their kind of records or in some way estimate the proportion of clients that would have problems with different substances that were part of the reason for seeking treatment. And you can see that alcohol was the first, stimulants was second, but third was opioids. So about the estimate was that on average, about 25% of the clients in the psychosocial treatment programs had OUD, opioid use disorder. We asked programs about whether they provided any specialized services for their OUD clients. And you can see that over half said, yeah, they did something special or different for people with opioid use disorder. This actually varied by region. So I don't want to make too much about regional differences because of different response rates and so forth. But it really ranged from 70% in BC and Quebec said that they did something special, 60% in Ontario, 50% in the Atlantic provinces, and sadly, 45% in the Prairie provinces indicated that they did something special. When we asked them, well, what specialized services did they provide? Mostly it was OAT they were referring to, but over a third said that they did some sort of specific counseling or did something kind of different in terms of the intervention that they were providing for people with OUD. Unfortunately, we didn't ask for details about this. 15% made a referral to an OAT clinic or to a rapid access medical clinic, addictions medicine clinic to facilitate OAT or medical assessment at least. And then some programs talked about doing some special harm reduction programming with people with opioid use disorder. So presumably, training them to use naloxone kits and that kind of thing as well. I imagine that this 15% would be higher if we actually asked programs about whether they did that. This is what programs spontaneously described in terms of specialized services. So the good news is that most programs said that they admitted patients or clients who are on OAT when they were referred. And most programs, only a few programs, encouraged tapering either before the program began or during the program. And these were, mostly those solidly abstinence-focused programs that encourage the tapering. In terms of facilitation, this was also good news. Only 18% of programs said that they didn't do anything to initiate OAT for their clients with opioid use disorder. About a third said that they did through an outside referral. They sent them elsewhere. 23% said that there was an internal referral, and 30% said that their program actually was in the position to do the initiation with OAT. So this was good news. This was less good news. In fact, I'd say bad news. When we asked programs to estimate the proportion of their clients who have opioid use disorder that were receiving OAT, the median estimate was 28%. The mode, so the most frequent answer, was that none of their clients were receiving it. And then you can see that about 38%, less than 10% of their clients, and only 19% had most of their clients receiving OAT. Again, some regional differences here. Quebec is the winner. They were much more likely to indicate that their clients were receiving opioid agonist therapy in their programs. We also asked clients whether they had any data on outcomes, and almost no program had data on outcomes, but we asked them to estimate. Did they see outcomes for OUD as being the same, better, or worse than other clients? And you can see that a third of programs said that they really felt that the clients had worse outcomes. 18% said better. And these actually, the programs who said that the outcomes were better were the programs who provided internal initiation. So either they could do it as a program, or they had some, associated program that they were able to use. 42% said that the clients were more likely to not complete treatment. They're more likely to drop out compared to clients without opioid use disorder. In terms of barriers, we asked people, philosophically, is their program, against OAT? And that actually wasn't true. So that was one of our kind of research questions going into this was, how much is that a barrier? And the barriers were really very practical. Lack of staff or facilities, lack of safe storage, lack of the medical staff, and so forth. So we also asked them then, as a side question, do you provide naloxone kits on site? And 86% of the program said yes, they did. And those not doing it, most of them said that they would be willing. So again, it wasn't a philosophical issue. It was really, practical kinds of things. So sort of the good news and the bad news from the survey is there seems to be strong willingness to provide OAT, over 80%. The proportion of clients receiving it, however, is surprisingly low given this willingness. And the barriers are logistical, as I mentioned, very practical kinds of factors. And again, lack of outcome data is a barrier, is a problem in trying to understand some of this. But the programs that had internal facilities to provide this perceive their clients to have better outcomes than other programs. That would need to be determined. So that's the scoping review, the treatment survey, and then as part of that treatment survey, we asked programs to self-nominate if they felt like they were model programs or if they were doing something that they thought should be shared in terms of helping people with opioid use disorder. So not necessarily about OAT, but just generally servicing and providing good treatment and good support for people with OUD. And then we followed up and did qualitative interviews with those programs. So I'm going to pass it now to Amber, who's going to tell you what we heard from programs. So Amber, over to you. I'm going to stop sharing, I think, and you're going to start sharing.
Yes.
Yeah.
You can see my screen, okay?
Okay, so I need to still stop. I haven't been able to figure out how to stop here. Yeah, can people see Amber's?
Sorry, it just kicked me out. Okay, one sec. Okay, you can see my screen okay?
Not yet, Amber. There we go. Yep.
Okay. Okay, yeah, so just as David mentioned, I'll present on the findings from the interviews from the program managers who self-identified as being a model program. So as mentioned, when completing the survey, managers or stakeholders were asked to self-identify if they thought they were a model program for treating OUD within psychosocial setting. So out of the 214 programs, 60 self-identified as being a model program. And then these responses were discussed among the research team to identify programs for further exploration using qualitative interviews. And 20 programs were selected for interviews, and then 14 responded and completed. So from these interviews, model program summary report was completed. However, we found that a specific model program was not really identified. Rather, examples from the program were collated with the aim of producing a list of sort of best practice recommendations. And then from this data, we really interpreted an expression of need from both the survey and the qualitative interview data of a need for guidance to support best practice for treating opioid use disorder within a psychosocial setting. So we developed a KT resource, and really the goal of this resource was to integrate and synthesize the top project findings, so including the case study interviews, as well as some information from the survey, into really like a accessible, user-friendly resource to really support addiction program managers and service providers in designing, developing, and delivering treatment for individuals with opioid use disorder within their psychosocial treatment program or setting. So in developing this resource, we were guided by two questions. What is important to know for individuals with OUD in psychosocial and recovery-based treatment programs? And what are the key practice principles for providing treatment for individuals with OUD within a variety of psychosocial settings, including outpatient, day programs, and bed-based treatment? So just some overall findings from our interviews, we found that there's really a lack of targeted psychosocial interventions for OUD. So outside of opioid agonist treatment and naloxone distribution, there's really not a clear differentiation between treating OUD compared to other substance use disorders. We also found that there was an identified need for improved evaluation methods for the treatment of OUD, including looking at short, mid, and long-term outcomes across a variety of domains. And then we identified these key practice principles, and I'll go through those next. So identified key practice principles among our participants for the treatment of OUD within their setting included the importance of integrating opioid agonist treatment within their treatment setting, ensuring that the treatment is really client-centered and recovery-oriented as defined by the individual, making sure to support delivery of care that is anti-racist, culturally safe, and trauma-informed, including peer support workers in the staffing model, facilitating continuity of care for individuals and really ensuring that there's a network of services to support treatment and post-treatment, including access to telehealth and virtual care. So most of the interviews that we did were during the pandemic. And so this was something that, really came through as just sort of increasing accessibility. Employing case management strategies and ensuring that, as David had mentioned, that drug poisoning prevention education, including naloxone distribution and harm reduction supplies are made available. And then lastly, as mentioned in the previous slide, all sites really highlighted the need for improved quality improvement and evaluation activities. So now I'll just go through the practice support document. I'm just going to pull it up here. Yeah, so this is the practice support document that we developed. It's available on the website, and so it's available in English and French. And it really is just accessible document that service providers can use to really sort of guide, developing their programs and supporting their practice. So just looking through our table of contents, so we have provided just an overview of opioid use disorder, some screening and diagnosis tools. What are some considerations to think about for individuals in your treatment program? We do provide an overview of opioid agonist treatment, so looking at the different types of treatments available and how to support individuals on OAT within psychosocial settings. And then we go through more detailed those key practice principles and really look at ways you can apply this in your treatment program setting. And then we also review some evidence-informed psychosocial interventions for OUD. And then we have quite a few additional resources that can help support learning and training in this area. Yeah, so this is our guide. Definitely recommend checking it out. Just kind of show you what it looks like. So we'll go through the different types of OAT. What does it look like if an individual is new to OAT or if they're already on and they enter the program? And then we, again, as I mentioned, just go through all of our key practice principles and linking to resources that can help support implementation in your treatment setting. And yeah, and then some psychosocial interventions, which David talked about earlier. And then, as I mentioned, just a bunch of resources that can support this work. And yeah, and then there's just another page that I'll just show you quick here. And so this is on the CRISM page, and it just is a nice sort of area where you can access all of these documents. So we have the top survey report, the publication, the scoping review in the dashboard. And then you can also access this practice support document on this website here. And I think that is it for me. And yeah, I'll pass it along to Capri.
Thank you so much. I'm just going to share my screen now. So hopefully that's working. Everybody can see that. Okay, great. So I'm very pleased to be here. My name is Capri Rasmussen, and I'm the Clinical Administration Manager with Aventa. As you can see from our slide, we're been in operation for the last 54 years. We're located here in Calgary, Alberta, and we accept clients from across Alberta. So I'll only briefly kind of talk about the overview of our agency. I really encourage you to check out the website. We have our brochure, application, and a virtual tour with photos and things like that, and more of an in-depth overview of the continuum of care that we provide. But Aventa is based on the work of Dr. Stephanie Covington, who is an expert in women trauma and addiction, and also a woman in long-term recovery. And so using her curriculum as a foundation, we provide concurrent, capable, trauma-informed, gender-responsive addiction services for women. Our live-in programs range in length from 7 weeks to 14 weeks, and we have 3 levels of care there. So you see our phase 2 program being 7 weeks, or young adult being 90 days. And graduates of either of those 2 programs who want and need more full-time live-in programming can apply to go to our phase 3 14-week program. Phase 1 is just when somebody comes in early for programming and has some one-to-one time and is not quite in group yet, some stabilization time and so on. Not detox, though. We do work with detox partners for detox services. We also provide on-site medical services. We have a consulting physician and a consultant psychiatrist, and we have nurses 5 days a week. We have specialized programs for FASD prevention and intervention, including a specialized program for pregnant women who are using substances, and also programs for women who are living with FASD themselves. As well as after people complete the program, they do have aftercare support, including a weekly counseling group, social and mentorship opportunities, and other alumni programs as well they can stay in contact with. We do have some pre-treatment outreach programs as well for clients with higher needs through a partnership with McMahon called the Journeys Program. Again, more of that's on the website. Today, I'm going to focus a little bit more on some of the tips for success and challenges specifically around OAT. In 2022, 2023, in all of our programs, about 26% of the clients at some point were involved in an OAT program. There's our website and phone number there as well. There we go. So these were just some tips for success, and I want to take a moment though to really go back to what was already mentioned around the key practice principles and the guiding documents. I think those are really important. That these are maybe more specific ideas or suggestions, but they have to be there with the underpinning principles of things like trauma-informed care and these larger philosophies. So I do think that one of the things is to make sure there's congruence with agency philosophies around OAT, and I think one of the ways is to really understand that as part of medication, as part of treatment. So helping if there's going to be a change for the organization, then to make sure that the work's been done around congruence with the philosophies as well. One of the ways is to identify champions, so who in the agency is really interested and passionate and will help start engaging with staff to cheerlead the process of accepting OAT and treatment. Aventa has been accepting clients with OAT for as long as I know of, and I've been working with Aventa for in 2 different stints for 16 years, and it's been over 20 years that OAT has been at Aventa for sure. I can't tell you exactly the start date. Staff buy-in and readiness. So this is working on the staff and any change management, understanding how it fits with agency mission and philosophy again. So just making sure that you have that process if you're bringing this on new. This is important whether you are starting OET in your organization or just working with it now, is that ongoing staff education and training. And we've been able to partner with our local ODP clinic and also the virtual ODP clinic to provide ongoing training to staff. So we have clinical training sessions, and we'll bring in stuff around opioids, overdose prevention, and OET on a regular basis. This also then includes written information within your policy and procedures and your staff induction and things like that, as well as, you know, ongoing supplemental online training. I think a really important component of this is that ongoing quality improvement. So as you learn things, as we know better, we do better. So as we learn things, we get tips from the staff, the clients, partners, things like that. Then we examine the ways that we work and make adjustments in all areas of our programming. I think it's also important under education and training to consider the special issues within the populations you're working with, where you provide services, and the communities that you work with. So being a women's focused center, it's really important to consider the gender responsive concerns of our population, specifically around women, pregnancy and parenting. And in particular, the stigma that's often associated with women who are parenting or pregnant and using opioids and or on the OET program. So having an understanding of that. So we work closely with, for instance, a perinatal collective, so that we have, you know, good perinatal supports for clients in the community that understand the role of OET as being helpful in pregnancy, things like that. So I think that's always an important issue. So considering who you're serving and what some of those local issues might be, and looking at the gender components as well. Pharmacy partnership, this is huge. This is a key. So this is really a key thing. So I think that will look different in different settings, but we are very fortunate to work very closely with a pharmacy that we work in partnership with, that has, you know, good extended hours, open very late, and they are across the street. They're 1 block away. You can see them from the center. So they are a partner to provide support to clients and staff around medication education and so forth. Some places might have mobile pharmacy that can provide on-site support as well. And then they also, what's really great in our main center is our clients actually dose at the pharmacy. And so they also provide the witnessing as well and client education. Also, they provide Sublocade injections. So our clients can get any ongoing injections that they need at the pharmacy. So just exploring how a pharmacy support could be applicable in your organization, I think is great. Continuity of care and collaboration is really, really important. So working with pre and post treatment supports, ensuring clients can continue to access OET after treatment. So we don't want people running out of funding and things like that. So making sure that they have ongoing funding. So assessing that when they're in treatment. And also then working with the ODP clinic for support during treatment and ensuring that they have their prescriber support when they leave treatment as well. This can also mean, you know, other specialty medical clinics. You've mentioned RAM clinics before, and other clinics here that work with vulnerable populations, as well as our local addiction and mental health offices that are provided through Alberta Health Services. On-site medical services are great where possible. So we are fortunate to have nurses 5 days a week, and, you know, they take care of all sorts of health concerns, as well as a consultant physician and psychiatrist. But where not possible, it's important, I think, to develop relationships with those other specialty clinics. So the RAM clinic, you know, different clinics that provide services to folks experiencing homelessness and addiction, and also walk-in clinics. So clinics that are accessible on an ongoing basis. We're fortunate to have 2 walk-in clinics very close by as well. And then also, sometimes outreach services can come on site. So we actually have places like SafeWorks coming on site with nursing staff to do things like, you know, additional harm reduction counseling, you know, other STI and HIV testing and treatment and so forth. So having some of those supports as well. Medication management procedures are really important. So in most treatment centers, there's going to be medication of some sort. So just integrating your OAT protocols and procedures within your general medication management, whether you're doing when clients are self-administering medication or you're doing medication administration, just ensuring there's congruence there, really clear information on OAT, how it works, and those types of things to introduce staff to that, but making sure that those procedures are there. I think some of those practice documents discussed already will give some tips to kind of work that out. Another tip for success is integrating overdose prevention strategies. So this starts right from the application. We actually have a sheet attached to the application that talks about overdose prevention, also talks about OAT resources, so how to access the virtual ODP clinic, naloxone kits, all of that type of stuff, talks about Sublocade and all that. So we have that information right at the application. We review that in the assessment as well. On site, we have ongoing training for staff from a first aid perspective to respond to an overdose, to understand what an overdose is, to understand naloxone. Clients have regular sessions with SafeWorks that comes on site to provide overdose prevention sessions. And clients are offered naloxone kits on site at several points during their treatment cycle with us, and encouraged to take a naloxone kit for free and are provided that. Another thing as well is you can see in this photo here, we started these opioid overdose response kits, and these are on each floor of our center, and they're unlocked but alarmed, and they actually have naloxone right in them, as well as awareness poster about signs and symptoms. So this becomes a visual reminder and also very accessible in case of an emergency. So those are available throughout the facility. I think that's an important one. In aftercare supports, we also again talk about overdose prevention and the risks, and provide again those resources again in aftercare and discharge planning. So possible challenges, I think some of these possible challenges are met on the first page that about tips for success, but just that change management. Again, if you haven't done OAT before, making sure that you do that process, get those questions and concerns out, get the procedures, get the facility set up, all that kind of stuff. Client funding for OAT, so this comes up. So two ways that this can be an issue is that clients don't have funding to start it, or the funding runs out during treatment or closely after. So just being really aware of that. So one of the things we do is we assess clients' medication funding in general, because they can run out for other medications as well, and then work with them to access supports for medication funding. So in Alberta, that would be like social assistance and other types of benefits to access for ongoing OAT and other medication funding. Dosing changes during treatment, that can be a challenge in the sense of clients adjusting to that and then still attending our full-time group program. So our program is an intensive program. They are in full-time groups, morning, afternoon, and evening. And so it's a very intensive group approach. So, that can be an impact. So just really working with the prescriber, talking about that, trying to see if they can be on a stable dose prior to admission could be another option as well. And then having the pharmacy and the prescriber work together around that as well. Also, on a practical sense, even having things like making sure appointments are outside of group time. So we have an appointment time, so we work with the clinics. So they know to set our clients' appointments on certain days, things like that. Another issue that can come up is other clients' beliefs. So we're really transparent and communicate on our website and in our service contract with clients that clients on OAT are welcome and supported to attend treatment. So we want to make sure all clients know that and they understand that that is part of the program for some clients. Managing carries. So if you're going to manage Suboxone on site, for example, ensuring that clients are permitted to have carries. And then, when in our longer term program where clients might have carries on site, we actually work with the pharmacy and have them do daily deliveries. So they deliver the day before. And that just helps not having a lot of carries on site. And then if someone, for instance, discharged early and left without their carries, then they can still get their medication more easily through the pharmacy. And then also the witnessing doses, again, having policies and procedures and protocols for clients who have carries to take their own medication in front of staff and or using the pharmacy for witnessing doses as well. And then another one here is accessing community support. So one of the challenges here can be OAT restrictions at other agencies. So helping clients getting into housing and aftercare programs where OAT is not allowed. So one of the ways to combat that is having a good knowledge of where OAT is allowed and if there's any limits on dosing or things like that or levels. And then also being a champion and supporting the community and increasing OAT acceptance. So talking like we're doing today about how it can work, what it looks like, understanding it as a tool in the toolbox for recovery. So that's some of the ways that we might do that as well. I just wanted to quickly go over a few Alberta resources. So this is the AHS Opioid Dependency Program, and then the ODT Virtual Training Program, which is free and is accessible across Canada. And I think other provinces may also have some training resources online as well. AHS has quite a bit of online training that's free. They have a trauma-informed care series. They have addiction and mental health webinars that are free online, even for persons who are not part of AHS. And then there's also the Alberta's Virtual Opioid Dependency Program. So this is a great resource. They can meet with their clients virtually. They work with lots of folks living in rural areas and so forth. Specific to Alberta is the Opioid Agonist Therapy Gap Coverage Program, which provides funding for clients who have no other funding to start OAT right away, and then working them towards things like Alberta Works and other long-term funding programs. So that's a great resource as well. And in Alberta, Sublocade, the injectable, is also covered as well. I think that's all for my presentation.
Thank you very much, Capri and Amber. Yeah, that was very interesting. And Capri, it's, you know, I guess two kind of take-home messages from you. I mean, one is, it sounds like part of the success you have is that it's very much, OAT is very much an integrated part of your program. So it's like any other service you offer, and staff are, you know, on board or expected to be on board. And but you pay attention to that. You make sure that staff have the appropriate training, they're comfortable with different aspects of it. And you know, that seems to be one of the keys. And then the other key, I guess, is that I guess if there's a will, there's a way. Is that you've kind of over time evolved a way that you can offer this that is you know, efficient, sort of not particularly costly, because you're really collaborating with other services, and but at the same time you need to put sort of energy into it. Like somebody needs to figure out the funding, and somebody needs to figure out the stabilization of the doses, and like, you know, that there's, well, not somebody, but you know, different people for different needs. Is that, am I getting it right?
Yeah, and I would say with all of that, partnership is essential, right? We're not doing this alone. So how do we work? You know, and there's lots of services that will do this. Like I said, like pharmacy support, ODP, and things like that, that will be able to provide a, you know, a key component of that. So I think that those are all really important aspects.
Yeah, yeah. So I encourage people to put questions in the Q&A if you have questions. There's one very interesting comment/question directed at me about my comment that in our survey, we found that most of the barriers that programs identified, you know, I labeled as practical as opposed to philosophical. And the person making this comment, I think, makes a good point that, you know, sometimes how resources are used and whether resources are available is philosophical. And I absolutely agree with that. And, you know, decisions that programs make around how they use resources, or decisions that funders make about what funds can be used for, you know, undoubtedly play a role here. You know, I certainly am familiar with programs that are residential bed-based programs that their involvement with OAT is a bit token, and it's not integrated in the same way that Capri is describing. And I know that kind of tokenism is in part discomfort, like it's out of their wheelhouse for a lot of staff, but also is philosophical, that they're not comfortable with the idea not because they're not trained, but because it doesn't fit their philosophies. So I think that's true, and I think I was interested to hear the Capri describing how they actually attend to that, and they make sure that staff are knowledgeable, and that other clients are knowledgeable and accepting, and it's very transparent that this is part of what is offered. So it was a good comment. It made me stop to think, and I agree with it.
We don't have any other questions that were typed in, so I would ask attendees if you have any other questions or comments, throw them into the Q&A panel. Otherwise, we'll be done ahead of time.
So one of the offers we would like to make, I guess, is if there are programs that are really, encouraged or thinking about rethinking their ability to provide OAT, we'd be happy to be involved and try to brainstorm ideas and make connections and see whether there's any of our experience that can be helpful in making it happen. So Denise is the contact person here, so please let her know if that would be of interest. We're also particularly interested in getting feedback on the resource document, the practice document that Amber described. So if there's other information that you think would be important, or sections that you feel should be more detailed or eliminated, or any feedback you can give us, we would appreciate it. And also get a sense of whether you feel like it is inspiring any changes in the clinical practice that you provide as well.
On the very last slide of the presentation were some links to the evaluation and follow-up survey. So if one of the presenters can throw up that last slide, can you share the very last slide?
I have closed my PowerPoint, so
I can do it.
Okay.
And then there was just a question also from Brendan in the Q&A just about did you identify differences in outcomes for programs that do not or do taper with the goal of abstinence?
Yeah, so the outcome information we have is far from perfect, right? Because it's programs' estimates of their sense. So what we found was that it is programs that are abstinence focused that were more likely to indicate that they do want their clients to taper. They were also less likely to they were more likely to say that opioid use disorder clients do more poorly. But I'm not tying those two things together. But certainly, the practice guidelines would not be that that clients be tapered, and that's based on risk of overdose and then just general poorer outcomes. So you can assume that outcomes might be poorer for the folks that are tapered, but that's a bit speculative.
Yeah, and there is a section in the practice document that reviews that piece about if you're supporting a client that's coming into your treatment program or setting that is already on OAT, and really, emphasizing the importance of continuing them at their stable dose and not moving towards that tapering piece because of the risks associated.
Good.
There's an additional question that came into the chat there. Wondering if you can talk about contingency management. How is it included in the program?
So I can talk, generally about contingency management.
Yeah, I
So,
think so. Just says, can you talk about contingency management? How is it included in the program, or
okay.
what role might it play, I guess, in the programs?
Okay. Yeah, so contingency management is, as I mentioned, is, providing incentives for individuals to stay engaged in different aspects of the treatment. And it actually, if you had to kind of rank order interventions in terms of their evidence base, you probably would put OAT at the top and contingency management kind of, not far below that. Even though it's challenging to implement in some ways. But it originally was developed for use in methadone clinics, and what was rewarded were drug-free urines. So people would come in to, with methadone, you needed to come in to the clinic on a daily basis, and every time that a person provided a drug-free urine, then they, received, some sort of reward. And it had, and then it evolved in that it moved from, a consistent reward being offered for a drug-free urine to there being a lottery kind of system where people would not get a reward, but they would get a chance of a reward, which made it then kind of a little bit more economically efficient. And the rewards would be often, prizes of different types, sometimes, depending on the population, very practical kinds of things, or they could be financial rewards as well. The other way it's evolved, though, contingency management, is that it also can be used to reinforce attendance at treatment. So for outpatient services, for example, people just by attending can receive rewards. And yeah, so it's something that even though there's a strong evidence base, it hasn't been as widely adopted as it probably should be. And again, there may be some philosophical kind of resistance to it that, people should be internally motivated, and, providing external motivations, might erode internal motivations. And there's not really evidence for that. It really seems to be a good adjunct. So there are some OAT programs that routinely provide it. I know that there are many more that are interested in making it available, but it certainly isn't very routine.
I see in the chat that there's a question directed at me about Aventa and the waitlist, so I could respond to that. So Aventa does have approximately a waitlist around 3 months or so. I'd have to check with the admissions team to be exact. That is a challenge. So, a couple of ways we've worked on addressing this is actually, we started with only 16 beds. We now have 72, and we still have a wait list. So, it is an ongoing challenge. Another aspect of managing that wait list, of course, is through our Journeys partnership with McMahon, we can provide extra pre-treatment support to clients with higher needs within the Calgary area, and also can provide pre-treatment supports to women who have FASD, whether diagnosed or suspected, in the pre-treatment phase as well. So how it works to come into Aventa, it's a two-part process. So it is an initial application. We also made some changes so they can apply right online, or they can download the PDF. Then they must call for an assessment, which can also be done virtually or in person. Again, trying to address some of those aspects of access. And then they will have an admission plan made with them, including detox, community safety, things like that, and then try to get them into treatment as soon as possible. With all treatment and all addiction-related concerns, there may be changing levels of motivation. So if someone drops off the wait list, we maintain a wait list and can pull somebody in early as well. So there can be different factors that might impact the length of waiting. So, client readiness, access to, medication that they might need, things like that, and then just space in the center as well. We'll also refer people to day supports through like AHS and other services as well during that waiting period. So it's very individualized with the client to see what we can do to support them during the waiting period, and then have them come in, you know, as soon as possible. But of course, being a live-in facility, there is constraints. So hopefully that answers the question.
Any other final comments or questions?
Well, there's a comment and a question in the chat. We can go back to that one from Brian.
Out in the chat.
Yeah, I think he's just mentioned how finds that there's a lot of stigma within the general addiction community around OAT and how opioid agonist treatment is still an opioid, and just mentioned how education around opioids and how OAT works is really key, and that he finds it interesting regarding what stage of change people are in, and how that can sort of connect to their use of OAT.
Great. So again, appreciate you providing some feedback and feedback on this presentation, but also on the document that we've put together, the support document. And thank you for your time and your interesting questions. And we're available. So if we can help you at all, please be in contact. So I'd like to thank Capri and Amber as well, and Denise and Barb for your background support as well. Thanks, everybody.